Welcome to Going Antiviral, the podcast for the IAS-USA, a professional continuing medical education organization focused on HIV and other viral diseases. I'm Dr. Michael Saag, professor of medicine and infectious diseases at the University of Alabama at Birmingham and volunteer member of the IAS-USA Board of Directors. Welcome to the Going Antiviral podcast. Today, June 27th, 2024, we are speaking to Dr. Suman Srinivasa, who is an assistant professor of medicine at Harvard Medical School and the Massachusetts General Hospital. Dr. Srinivasa is an endocrinologist who focuses on body composition and metabolic abnormalities observed in people with and without HIV, and serves as co-director of the Miracles HIV program, which stands for Metabolic Investigations, Researching Adipose and Cardiovascular Health in HIV. Her clinical research focuses on exploring mechanisms and treatment strategies for inflammation and cardiometabolic disease in HIV. She has received several NIH awards and is a recipient of the Endocrine Society Early Investigator Award and the Croy Young Investigator Scholarship, as well as a two-time recipient of the Women in Endocrinology Young Investigator Award. Today, we're going to focus on treatment of diabetes and the management of weight gain with novel GLP-1 agonists. Suman, welcome to the program.
Thank you so much. It's such a pleasure to be here today.
Well, we'll dive right in. What's all this fuss I hear about GLP-1 agonists? Is the hype warranted?
So yes, you may have heard about them more recently. So this is really, truly a transformative time for our patients, both for those that have diabetes as well as those who have obesity. In recent years, the GLP-1 receptor agonists have, I think, become one of the more rapidly expanding fields in medicine. And these medications really have the ability to have far-reaching effects for our patients. Now, what's interesting is that even though these medications have gone viral, and more recently, I should say, the GLP-1 receptor agonists have actually been around for some time. The earliest preparations were available for diabetes about 20 years ago, and have even been used for weight loss as early as 10 years ago. But it's really just as of now that we are starting to understand the powerful impact that these medications can have on weight reduction and so many other metabolic complications. So for all of this, and really it's this breakthrough, the breakthroughs that have happened more recently, that this hype may be warranted.
Yeah, so we're going to get into a lot of the effects here in just a second, but let's take a sidebar just for a second and maybe you can explain how they work. What does a glucagon-like peptide do?
Absolutely. So, glucagon like peptide 1, or GLP-1, is an incretin peptide hormone. Now, it's secreted from the small intestine following food ingestion, and it really acts to stimulate insulin secretion, the so called incretin effect. And it also works to inhibit glucagon release, thereby producing glucose lowering effects. And GLP-1 receptor agonists, or GLP-1RAs, as we've been referring to, are a class of medication that mimic this physiologic GLP-1. And really, due to these mechanisms, GLP-1RAs were first leveraged for the treatment of diabetes. These agents are now starting to be referred to as NUSHs, nutrient-stimulated hormone therapies, and that's really because of the interaction between dietary components and the endocrine system, leading to modulation of hormones that result in potentially beneficial changes in metabolic dysfunction.
Yeah, so you mentioned that they increase insulin secretion, right?
Correct.
Okay, but I always thought about diabetes mellitus type 2 as being a hyperinsulinemic disease. Am I missing something?
Yeah, that's right. So, in with type 2 diabetes, we typically think of this as an insulin resistant state. So, your body is making insulin, but it may not be using it as well. And as I mentioned, GLP-1s have sort of a variety of mechanisms as well. So, all of that together may be contributing to its benefit in diabetes.
So, does it increase the susceptibility or sensitivity of cells to insulin, do you think?
Yes, it's possible it's doing that, and it may, it may be also that there is some, which we'll talk about, some weight reduction, which will also lead to insulin sensitivity.
Right. I mean, I'm not going to go into the digress into how does metformin work because most people just wave their hands and go, it does. So I'm not going to expect that we know everything about GLP-1 receptor agonists. So obviously, you've used this as an endocrinologist, as you said, probably for your whole career, going back 20 years ago. Give me some examples of how you first started using these in the non-HIV populations.
Absolutely. And again, I think, these agents, even though they have been around for some time, weren't necessarily considered the first line therapies. So, really, our comfort and familiarity with them has been happening more recently with all of the breakthroughs, like I mentioned. And it's really with the newer preparations that have evolved that we're seeing robust effects in terms of their efficacy that have probably prompted us to use them, these days, and are considered first line based on indications. So we do use these medications for indications of type 2 diabetes as well as obesity. In terms of when you would use them, the indications currently extend to diabetes, either when the A1C is uncontrolled and above 9%, or they can be used in diabetes regardless of A1C when there is any history of cardiovascular disease or kidney disease. Um, with regards to obesity, we tend to use these medications. They're indicated when the BMI is above 30 or when the BMI is above 27 and there is at least one other metabolic comorbidity, and oftentimes, the patient will have to have demonstrated failure of lifestyle modification for 3 to 6 months before these medications are are used and approved. We also know now that these medications um, have been extended in terms of coverage to also be approved for those who are obese who have a known history of cardiovascular disease as well.
So it sounds like in your practice, you're outside of HIV, you're using it for higher A1C levels, for comorbidities that happen to be traveling with diabetes, and for different BMIs. And I suspect, because your precision on how you describe this, it may translate into how insurance companies will agree to pay for these, because a lot of us will maybe get to this at the end. A lot of us are having trouble when we want to use them getting approval for payment. So those are the kind of benchmarks that the insurance companies are using?
Absolutely. Those are sort of the FDA approved indications. I will have to echo access has been an incredible issue for, our population of patients that need this the most and would benefit the most. Um, you know, um, these medications are not approved via Medicare for, or any anti-obesity medication is not typically covered by a Medicare. Now, with Medicaid, it can be the preference of the state in terms of whether there's access to these medications. Being from Massachusetts, we are fortunate that Mass Health does provide some coverage for these anti obesity medications.
So it's interesting. I bet that Medicare covers for morbidly obese people bypass and bariatric surgery, which feels like it's more invasive and more hazardous, right? But yet they won't cover this for morbidly obese patients or others who've got that plus other abnormalities. That's really interesting.
Yeah. Well, and the indications for bypass are somewhat different. Typically, these are individuals that have a BMI above 40
Yeah.
or a BMI above 35 with a comorbidity. And it is based on really data of bypass showing that it can actually put diabetes in remission, that this has been probably approved by insurance companies.
Got it. Okay, well, let's make a transition to HIV patients. So they, as we've been hearing about for at least a decade, as people are starting on antiretroviral therapy, and in particular, some of the integrase inhibitors and TAF seem to be implicated some in a post-treatment initiation weight gain, especially over that first year, that can be significant. And what I saw at the CROI meeting was that the GLP-1 agonists are helping pretty substantially with this. And I might add, it doesn't seem like much of anything else has worked. That included changing the regimens on antiretroviral regimens. That included starting metformin, encouraging diet and exercise, which of course we all do. So, what's your interpretation of the data that's been presented so far with HIV patients?
Yeah, absolutely. So there are handful of studies in HIV. We definitely need more studies to help guide us. But what we do have has been quite useful. Many of the studies are retrospective in nature, harnessing sort of medical records. But there have been two larger studies more recently, one of them being a randomized controlled trial, this being led by Grace McComsey and Alison Eckard, which was quite exciting to see. These results were presented at ID Week as well as follow up data at CROI. In the past year. And in this particular study, they were looking at semaglutide for body composition among those with HIV with lipohypertrophy or increased waist circumference. So they recruited individuals that had a BMI above 25 with increased waist circumference, and then they were then randomized to a lower dose of semaglutide of 1 milligram versus placebo, I believe over 24 weeks. And again, their primary endpoint was really to look at body composition, which is so important in HIV because we're really thinking about how is the fat distributed. And importantly, we think about the visceral fat, which is a highly inflamed depot, which contributes to metabolic dysfunction. So in the study, it was quite impressive. They saw that semaglutide actually reduced the visceral depot and the subcutaneous depot, each both by about 13 to 15%. And in addition, they looked further at body composition, and they also saw that in general, these medications reduce both fat and lean mass. And in their follow-up data, which was really exciting to see also, it looked like secondarily these medications may have some anti-inflammatory potential. There was actually a significant decrease in HSCRP, IL-6, as well as CD163, which are important markers of inflammation in HIV.
Yeah, so if we take it then a step further, I also saw some other presentations at CROI that it reduces liver fat. It improves cardiovascular function and seems to protect against progression, and maybe through the mechanisms that you just elucidated, that it improves cognitive function, some preliminary data, that it reduces craving behavior, so it could be used in substance use disorders. It feels like it does everything but cure asthma. What what are you noticing in the literature, and do you think that all those claims are on target?
Yes, wow. Well, the list just goes on and on these days when we think about GLP-1s. It's hard to keep up on all the data actually because there's just new findings every day. So there was some data specific to fatty liver disease, as you mentioned, in the HIV population. These were through a study that was presented at CROI, the Slim Liver study by Jordan Lake and Christine Erlandson. And they did see in an open label study, when semaglutide 1 milligram was used, that there was a decrease in intrahepatic triglyceride content, as well as a resolution of NAFLD or MASL these days, as we call it, in about 30% of patients. So it was quite effective. But again, this was in an open label study, and hopefully these results will play out in a more rigorous study as well. But quite exciting to see that data.
Yeah, and even though it was open label, it's hard to just imagine that those reductions in intrahepatic fat were the result of some bias, right? I mean,
Yeah,
it feels real, doesn't it?
it did feel real, especially since there were other changes that you would expect with these medications. There was weight loss, there was improvements in dysglycemia, as well as lipids.
So, thinking of other uses that I mentioned a bit ago about how this has impact not just on metabolic, but maybe some other things like behavioral or craving, and that people might have with drug use, substance use, perhaps even binge eating disorders. What do you know? What have you heard about data on these in these domains?
Yeah, it's been quite exciting to think that maybe these medications could have some impact on addictive disorders. As of now, the data is mainly preclinical in nature, and there is, in rodent models, it's been studied in terms of alcohol use, nicotine, opioid, and cocaine use. And there does seem to be some benefit. We have very limited human clinical studies, but they are on the forefront. And, we will hope to see data from this. So the idea here is that there are GLP-1 receptors in the reward center in the brain, and that by stimulating these receptors, there's a decrease in dopamine, and potentially that this could reduce feelings of reward that are often associated with cravings. And you can see that there can be some parallels in the circuitry here, in behaviors such as overeating, or other behaviors such as consumption of alcohol, for example. And in fact, there's been one preliminary human study in which they saw that application of these medications, in fact, does reduce alcohol consumption in a subset of individuals with obesity. So this really needs to be studied more rigorously, though, but it's exciting to think that there might be additional applications, and this would have particular relevance to people with HIV as well. Um, we also know that there may be some effects on neurocognition. Again, these studies are really in their preliminary phases. There have been some studies in diabetes where it's shown that these medications may prevent a decline in cognition and potentially improve memory scores. And it may be linked to a reduction of inflammation in the brain. But again, I think we need to understand this all further. And, just in the, past couple weeks, there's been really other data on hypertension as well as sleep apnea. So the applications are really quite extensive.
So I'm wondering, first off, one of the things that everybody asks me is, how do you pronounce this? And I've noticed that some people say semaglutide, other people say semaglutide. I guess it's like advertisement and advertisement, as it doesn't really matter.
That's right. Tomato or tomato.
Yeah.
Exactly. I've also heard it pronounced both ways. I tend to say semaglutide.
Yeah, I've kind of come around to that as well. Um, so when you're thinking about HIV patients, um, what would be the patient population that you would really go to this? And you mentioned it's becoming first line. Some of the insurance companies are asking us to have a trial of metformin first and demonstrate that it didn't do anything before they'll approve it. But in your ideal world, in terms of what you see right now, who would be the patient population, or what is the patient population that you would say, yeah, we should really go to that first?
Right, exactly. So I think, in general, you know, the same indications that would apply to the general population would apply to people with HIV. So if there is uncontrolled, diabetes, or a history of cardiovascular disease or kidney disease with that, or there is a BMI above 30 or above 27 with a comorbidity, I do think these may be indicated. Now, I think that with weight gain, it's always important to take one step back and just make sure there's no underlying cause initially that could be easily treated. If there is, known hypothyroidism, for example, we also know that people with HIV may be at risk for hormonal changes that may be associated with body composition changes like hypogonadism or low growth hormone as well. So you still want to do a thorough workup to see if there is an underlying cause. And if you don't find another underlying cause, then I think it is reasonable and, based on the efficacy and the benefit of these medications, really should be considered. I think, one of the um, really wonderful thing about these medications is, their cardiovascular benefit and protection. We've known for some time through the large studies of diabetes itself that tight glycemic control itself does not reduce the risk of macrovascular complications and has not necessarily been associated with, improvements in cardiovascular disease. So it is really, um, unique to these medications that they are providing cardiovascular benefit in addition to glycemic and weight control. So it's sort of a comprehensive package.
Right.
um, One nuance to this is that in the studies where we do see cardiovascular benefit to these medications, these were among individuals that had a known history of cardiovascular disease. Now, we still have to explore whether this can be extended to individuals who don't have a known history or who have a low risk, which is highly applicable to people with HIV whom we know to have subclinical heart disease and an increased risk of cardiovascular disease.
Right. So let's say you had somebody with cardiovascular, let's say heart failure, um, and the cardiologist recommends empagliflozin. Well, let's just call it Jardians. And you see the woman dancing on TV and all that, but that drug works by increasing glucose excretion in the urine, correct? And that
Correct.
translates into improvement in diabetes control, but also kidney function is preserved or improved, and cardiovascular data are there too. So, is it one or the other, or do you use both of these? Of the Jardiance-like drugs along with GLP-1? How do you think that's being approached these days?
Yeah, so again, these medications probably have different indications. So um, there are ongoing studies of heart failure with the GLP-1s, which I'll talk about a little bit. But really, it's the SGLT2 inhibitors right now that have shown benefit to patients with known heart failure in terms of reducing hospitalization from heart failure and morbidity and mortality. Now, that data is still forthcoming with GLP-1s.
Right,
There have been preliminary studies in obesity among those with heart failure with preserved ejection fraction where there has been an improvement in symptoms as well as maybe some function, but we don't know how that extends to hard outcomes like events. So, in this situation with known heart failure, probably the preference would be SGLT2 inhibitors.
right. And I suspect, like everything else, they'll look at combination therapies between the two, and that'll probably show at least some additive benefit, if not maybe more. And then the whole pharmacy budget will be blown because nobody can afford it, but that's a whole nother story.
That's right, yes.
Where do you, where our time is flying by, we're going to need to wrap up here in a few minutes, but what do you think the next 10 years will bring? Is just continued demonstration of benefit? What do you think will be, how do you think we might be using these even more so perhaps in the future?
Yeah, well, I think the pipeline is bursting right now. So we're going to see lots of new medications over the next 10 years. There's so many different combination medications in the pipeline. I really think we're at the forefront of new discoveries. But what it really comes down to is still trying to understand and unravel sort of the mechanisms by which there's an increased risk of metabolic dysfunction among persons with HIV. And really, if we try to discern these mechanisms, we can then provide HIV-specific treatment strategies and personalized medicine for our patients. But until then, we've really come across some great medicines that we have at our disposal. And, we'll continue to have to think about long-term strategies as well. The heterogeneity of disease will need to resolve some issues like access. But in general, it seems very promising. And hopefully we'll be able to make a real impact for our patients.
Yeah, it does feel like it's an emerging frontier. And a flashback to maybe the 1940s and 50s with antimicrobial therapy and into the 60s, where just was this explosion of opportunity to control infections. And now hopefully we'll be able to manage metabolic disorders as well as not just diabetes, but many other things that tend to interfere with certainly morbidity in life, but perhaps even mortality as well.
I agree.
Well, great. Well, our time is about up. Thank you, Simone, so much for being with us. That was very concise and very informative, and I'm sure we'll revisit this with you perhaps a year from now and just see what kind of progress we made, because things are moving very fast. Thanks again for being with us.
It was a pleasure. Thank you again.
Thank you for listening to this episode of Going Antiviral. Catch up on earlier episodes wherever you listen to podcasts, and check out the video versions of this episode and others on the IAS-USA YouTube channel. You can find these links in the show notes, or simply go to YouTube and search for IAS-USA, and there they are. Be sure to subscribe, rate, and review Going Antiviral on Apple Podcasts. This podcast is for informational and educational purposes only and is not intended to serve as medical advice. Opinions expressed in this podcast do not necessarily reflect the opinions of the IAS-USA or its affiliates. If you have a question you'd like answered on the show, you can send it to podcast@iasusa.org to be answered in a future episode.